Hi everyone, my name is Lahira, I'm a consultant anaesthetist, and this is my practical guide to intravenous cannulation. It's a systematic approach to access any vein. Now, just before I get started, I've got a Facebook group called the ABCs of Anaesthesia group, and I post a lot of content on that group. Also, please check out my website, www.anaesthesiacollective.com. Now, this presentation is really detailed, and the reason I made it so detailed is I really would rather that you have all the information that I know about IV cannulation, without missing anything, so that you have all the detail that you can slowly process over the time as you get more and more comfortable with cannulation. So obviously there's a really important skill, especially as a junior doctor, but all throughout your career. You improve patient care, you can decrease patient harm, and you may save a patient's life if you're able to do this really effectively. When you're an intern, it's one of the most common practical tasks that you'll ever do, so it will save a lot of time on a busy medical rotation. If you spend the minimum amount of time performing the 10 cannulations or so that you might have every day, you will save an incredible amount of time. And obviously this allows administration of a lot of different things to help your patients. It allows short-term access to the vascular system, and so you can give IV medications, antibiotics, antiarrhythmics, resuscitation drugs, and a lot of urgent medications, but also IV fluids and blood products as required, and IV contrast for diagnostic imaging. So what you'll learn from this presentation, we'll go through a lot of detail with the equipment and setup, handy tips to identify a vein, a step-by-step IV cannulation procedure, some extra tips to increase your success, and a few other considerations. So here's a pretty exhaustive list of the equipment that you may need to use. So I encourage all my junior doctors to make sure that they have all these things ready and just get very used to this process, so you don't forget things and don't delay the process occurring. In terms of the patient, make sure that the patient obviously consents to this procedure, and then consider the allergies. One of the most common allergies that will occur in patients is chlorhexidine. So it's really important that you check for chlorhexidine allergies as well as latex allergies. Ensure the patient is comfortable and warm. A warm patient vasodilates, a cold patient vasoconstricts. Now, obviously take care of your own back, for example, by making sure that the bed height is appropriate. So identifying a vein is one of those things that you really want to spend a lot of time on. It's time really well spent. When you apply a tourniquet, make sure that it's above venous pressure but below arterial pressure, so really not that tight. And you can use a blood pressure cuff if you didn't have a tourniquet to make this work for you and be really precise about what you do. Usually, most people would get the patient to open and close their hand. Muscular movement will promote venous flow back proximally as well, but also can help warm up the hand and just get blood moving and increase the metabolic activity of the hand to have more blood supply going to those muscles. Other people also talk about tapping and rubbing a vein. Just make sure you don't do this so that it actually hurts the patient. But what it actually does is tapping and rubbing the vein releases vasoactive mediators, and these can cause a dilation of the vein itself. One of the things that I find really useful is to lower the patient's hand. So make sure that the hand is below the patient's heart, and this way you make sure that you maximize the use of the patient's own hydrostatic pressure due to gravity, and that helps to vasodilate as well. As we mentioned before, warm patients vasodilate and cold patients vasoconstrict. So making sure that your patient's warm, because hospitals are invariably really cold places. The air conditioning always seems to be on high, especially in the theatre environment. So making sure your patients are warm before you go to see the patient is really useful. Sometimes you just won't be able to find a vein. Seemingly you cannot find a vein no matter where you look. And one of the things that have worked really well for me in the past is just to ask the patient, where is your best vein, and where have people found vascular access previously, and then go for that. One thing that's not really talked about is that after you access a vein, if a cannula is taken out, that can cause a bit of a problem if you don't apply pressure. It will cause bleeding into the subcutaneous tissue. So patients with very limited venous access, I always encourage them and tell them whenever someone has accessed their vein or removed a cannula to put pressure on that area for a significant amount of time so they don't lose that vein due to repeated trauma. So the next thing is, where will you put this cannula in? So there's a number of different sites with pros and cons for each site. A really good rule of thumb is I try to use the minimum size of cannula required and put it on the most distal vein that satisfies that need. So for example, you don't need to put a 14 gauge or 16 gauge large cannula for most just antibiotic and regular fluid administration. But then again, if someone's coming in through the emergency department or is at risk of serious blood loss due to whatever pathology they've got, whatever surgical procedure they're about to have, you might want at least an 18 gauge cannula. The reason I want the cannula as distal as possible as my first attempt is that, say you have a long line of a vein through the patient, from the patient's hand all the way up through the forearm. If you damage or if you miss the vein proximally, that really destroys any opportunity to access that vein from the hand area. Whereas if you miss in the hand area, you can still access the vein as it goes up the forearm. Blood flows from distally, proximally back to the heart. So you want to be able to, still be able to use those veins if you weren't successful in that first attempt. So I've just given a bit of a summary. The cubital fossa is great. There's big veins, it's perfect for resuscitation, and it's reasonably easy to access, but it's not really good for long term. So imagine patients trying to mobilize, trying to get up and do the activities of daily living, having that elbow bend constantly may kink that cannula. And they also have sometimes deep veins which might be hard to access. Now, the dorsum of the hand, again, really easy to access, very commonly accessed, especially in the theatre environment. Often they're smaller veins, they're good for longer access, and they're easy to access because they're quite superficial. But they may be tortuous, and occasionally patients may have more pain in that area as well. The forearm is a great spot again. Small and large veins are present. It can be good for longer term access, as it doesn't really get in the way of the patient's movements. And often that's what I'll try to use for longer term access. But again, they might be deeper than hand veins. And never forget the back of the forearm as well. Sometimes you can have really large veins that are really suitable and no one's accessed those veins previously. Just remember that a few structures do feel like venous structures. These can be thrombosed or scarred veins, which you just won't be able to access, and the biceps tendon that occurs in the cubital fossa as well. And also, as an anaesthetist, sometimes we have to gain vascular access in the most odd situations. So in the anesthetic context, we will use the wrist occasionally, the dorsum of the foot, and the saphenous vein as well. So just remembering that there's lots of areas that you can access the vascular system in an emergency. I generally also use a patient's non-dominant hand just for patient comfort. And then if a patient is genuinely difficult, know that cannula really should only be inside you for less than 72 hours. So ordering a PICC line or peripherally inserted cannula that can last for longer is really valuable. And this can be ordered through the radiological department or sometimes anesthetics as well. So one of the most common problems that you might encounter is accessing an artery inadvertently. So here are a few of the ways that you can differentiate and try to avoid this happening. First of all, an artery is generally pulsatile. So really have a low threshold for any pulsatile structures to just assume that it's an artery. Often the location can be a bit more hazardous in terms of accessing arteries. So the brachial artery is really superficial at the medial cubital fossa region. So just remembering that if you do have a vein that's overlying that medial region, often overlying or near the biceps tendon, just remember that your cannula shouldn't be going too deep for that structure, and maybe sometimes avoid it altogether. Sometimes the radial artery can also be accessed at the wrist. So if you're ever putting a cannula around the wrist area, there might be an aberrant radial artery. And again, check for pulsatility. You really don't want to give medications, especially anesthetic medications, through an artery. Generally, arteries are deeper, you might have brighter blood, and you might have high pressure or pulsatile flow back. So if you're ever in any doubt, ask for assistance or pull out that cannula and apply pressure. So I'm going to go through quite a number of steps here, and in the actual practical video, you'll see all of these come into action. So first of all, apply the tourniquet. I do this first because you want a bit of time for the patient to try to enlarge that vein and cause venous dilation. I always encourage my trainees to put a bluey under the arm. You never want any inadvertent blood spilling over the patient or over the floor or the bed that they're in. Always bring a sharps container nearby. At all costs, you want to ensure that you avoid any sharps injuries. The sad truth is that a lot of us will suffer sharps injuries through our career, and it's just something you really want to avoid by having these good practices in place straight away. Perform hand hygiene, and always think of the 5 moments of hand hygiene as shown by the WHO. Open the dressing pack, assemble all your equipment, always wear gloves, identify the vein and tap and rub as required, then cleanse the skin with chlorhexidine and alcohol in a swab. I then stabilize the vein, stretch the skin distal to the vein, and I'll go through that in extra tips. I pick up the cannula with my thumb and middle finger, and then we try to access the vein. So I first of all try to identify the point of needle insertion, and often it can be difficult depending on the vein, but bifurcations are very useful spots to access, as well as straight veins. Now, this doesn't mean that you can't access veins that are tortuous, it's just a little bit more difficult and probably needs a bit more expertise. I then approach at a low angle to enter the skin and then the vein, and roughly 5 to 10 degrees is kind of angulation that I require. Now, I always tell my students to advance the needle slowly. You want to know exactly what you're doing and know exactly at which point you get flashback, and there's a number of reasons for that. So I advance slowly along the axis of the vein until flashback of blood is seen. At that point, I stop advancing. You then lower the needle and the cannula together until they're flat against the skin, and take your time with this. The patient will be absolutely fine. I then advance both needle and cannula further into the vein, and the distance you advance that cannula is something that will be variable based on the size of your cannula, which means that the size of the bevel will be different as well. And we'll go through that in a second. After I'm at the appropriate distance, I then advance just the plastic cannula into the vein using my pointer finger, which was at that point free. All the time, I'm keeping all my structures the same, I'm keeping the tension on the skin, and I'm not moving anything differently. After that point, I remove the tourniquet, I occlude the vein proximal to the cannula with the fingers of my non-dominant hand, and then I remove the needle and place it in a sharps container. I then connect the IV bung to the end of the cannula hub. I flush with normal saline to ensure the cannula is successful, and I place a tegaderm or some kind of dressing over the cannula at its entry point to the skin. Then I use tape to secure the cannula in place. Now, let's go through some extra tips to increase your success. So those things include anchoring the skin and the vein, the correct cannula grip, and some important features of the cannula as well. So when you're anchoring the skin and the vein, I'll try to demonstrate here. You want to say this is my patient's hand here, which I'm trying to access. I'll use my non-dominant hand to anchor the skin and the vein. What this does is it can anchor the vein, but sometimes the vein will always move no matter what you do. But what it does, it prevents the skin moving as your needle enters. So you really want that to be tense enough. Not so tense that it flattens the vein too much, but tense enough that the skin isn't going to move too much. I generally use my thumb to stretch the skin distal to the vein. It's important that my thumb isn't in the way. So imagine that you're accessing one of these veins. I don't want my thumb to be in the way while I'm lowering my cannula. So I'll generally go off the knuckle edge there so that my other hand can lower the cannula as required. Now, the correct way of holding cannula, this will make or break whether you'll be able to, really efficient and competent accessing veins. So what I suggest is you want essentially to have this look. What this means is that I usually lay the cannula flat on a dressing pack. I then, using my thumb and middle finger, pick up the cannula like so. Just note that my pointer finger is out of the way. The reason is I want to use my pointer finger to be free to advance the cannula, but I also want it to be out of the way so I can see the flashback which occurs in the hub of the needle. Just remember the cannula is always below my fingers. That way I can get the right low angle that's required to do this procedure properly. So I don't want to look like that. I want the cannula as low as possible to increase that ability to have a very low angle. The next thing I might do is, no matter how good you are, sometimes you'll always have a tremor, and different people have different level of tremor. So what I use is my little finger to anchor myself on the skin, and that allows me to have very little tremor when accessing difficult veins. Now, there's a few important cannula features which we'll probably go through in the practical video as well. Now, this is a 16 gauge cannula. As you can see, it's very good at cutting into a vein. Obviously, the cannula has a very sharp tip. I'm just going to demonstrate with this over here that you can easily cut through, and it's very good at cutting through, which means, sadly, that it's also very good at cutting through the other side of whatever you're going through. So imagine that this packet that it came in is the vein. It's very good at accessing the vein, but very good at going through the other side. Fortunately, the flat bevel surface, hopefully you can see that here, that is a relatively non-cutting surface. So that's really important to know, which means that even though I can seemingly access it quite easily, if I was to try to cut the top surface of the vein, it's very hard to do so. As you can see there, I am lifting up against the plastic, but because of the angulation and the technology that's in these cannulas, it's very difficult for that to cut the top surface. So imagine that's a vein. It's very easy to go through the bottom surface, but it's very difficult to go through the superficial wall of the vein. So when I think about it, as I access the vein and get a flashback, I level so much that in a way I'm trying to cut the top superficial surface of the venous wall, because I know that that's going to be virtually impossible to do. Now the next point I want to talk about is the minimum distance you must advance the needle before feeding off the cannula. So just imagine that you've gone through the vein. So sorry, you've got flashback of blood into your cannula hub. Now the distance you advance essentially is not, you definitely don't advance the cannula straight away. You need to feed the needle into the vein such that you get the bevel in and a little bit. Notice that the cannula itself here only starts after the bevel ends. And this bevel distance is different for different cannulas. For example, this is a 16 gauge. That bevel is about 5 millimeters. The large 14 gauge needles, it's about 7 millimeters. These small 22 gauge cannulas, it's about 1 to 2 millimeters. So you have to advance far less before feeding the cannula in these small 22 gauge cannulas. It's a really important thing to know. Just imagine if you don't advance far enough, that means I will be pushing the vein wall away as I'm trying to feed the cannula off, and that's a really common way you'll miss your veins. Another important feature is the cannula size versus flow rate. So obviously, small cannulas have lower flow rates, and large cannulas have high flow rates. And in the back of these, you can see that there's actually some information. And this one here, a 22 gauge, it shows 35 mils per minute is the approximate flow rate that you can see there. This 14 gauge reports 215 mils per minute, and the 14 gauge can be upwards of 300 mils per minute. So really important differences, especially in a resuscitation situation. Now, some other important things to consider. Obviously, personal safety. Make sure that you're safe in that environment and you're at the lowest risk possible of any sharps injury. Also consider, does this person need a cannula? Whenever you're called to site a cannula for, say, antibiotics, can this patient have oral antibiotics? Does this patient actually need fluids, or are they fine with oral intake? Often my students and junior doctors also may not be as successful and not have as much experience. So it's always a contentious topic about how many attempts someone should have before calling for assistance. On one hand, you have to learn, but on the other hand, you really don't want to be subjecting your patient to that much trauma and harm. So generally we say with students, depending on seniority and comfort, 1 to 2 attempts is reasonable, and junior doctors, maybe 2 to 3 attempts is reasonable. There are some situations when you know a patient is very, very difficult for whatever reason, and you may call for assistance straight away, whether it's your registrar or consultant or your anesthetic department. Now, obviously, there's a lot of complications that you could cause, so really being mindful of this is worthwhile. Pain and distress, hematoma, nerve damage are just among the few things that you can cause. Now, one of the other things that I think is worthwhile noting that you may not even realize until you're further into your career is that there's some very specific reasons where you wouldn't put a cannula, particularly on one particular side of the arm. For example, if a patient is a renal patient or heading towards end-stage renal failure, they may need to preserve veins for arteriovenous fistula surgery to allow them to have dialysis. So if you do have an end-stage renal failure patient, you wouldn't want to put a cannula into that side where they were planning to do that operation. So if you have an end-stage renal failure patient, always check with the vascular team or even the renal team to find out if that arm is being used or it's being used for surgery later on. And that would be one of the reasons you'd need to cancel the operation if you access that vein inadvertently. Likewise, patients who've had lymph node dissections, often these are patients who've had mastectomies or breast cancer, they may have lymph node dissections on one side, which means that you can't really access that arm safely. So you'd have to go to the other side or other peripheral access. So obviously I'll get you to watch the real-time demonstration of IV cannulation. The link is in the ABCs of Anaesthesia Facebook group. But also, please post any questions or comments, and I hope you enjoy this video. Thanks.